So an advisory committee to the FDA met. They voted unanimously to approve this vaccine booster for patients over the age of 65 or for patients at increased risk of developing severe illness from COVID-19. Now, that's just the first step. So that's an advisory committee to the FDA. That does not mean that that's fully FDA approved yet. The CDC advisory committee will actually meet this Wednesday and Thursday. So we'll all be eagerly anticipating what their recommendations are. So we'll be, after we see what they say, then St. Francis will make plans to help out with those booster doses as well. So we've got the hut set up across the street. We have Springer Clinic available. When that data becomes available, when that recommendation becomes available, you can log on to stfrancis.com. There's a COVID-19 icon that you can click on, and that'll walk you through the steps. If you haven't gotten your first or second dose, or if the third dose booster becomes available, that's an easy way to sign up and get scheduled. A lot of folks that might be asking, why the booster? So you just shared some data that said that this vaccine is still highly effective at preventing hospitalizations and highly effective at preventing mortality. A lot of that data comes from an Israel study and other papers that have come out as well, but the Israel study specifically looked at giving COVID boosters to patients over the age of 60. And what they had seen is that about 4 months after getting the vaccine, some of those antibodies that you get from getting that vaccine had decreased, and the overall vaccine efficacy had decreased to less than 84%. And that, again, that was 4 months after getting a COVID vaccine. So whenever they actually put these patients in the study, they saw that giving a third dose lowered the rate of confirmed infections by a factor of 11.3. So that's actually talking about decreasing the spread of COVID. So that would obviously be a huge important factor for us as well. And they also saw that it lowered the rate of severe illness by a factor of 19.5. So even in those patients that already had 2 doses of COVID vaccine, you saw a decrease in the risk of severe infection and a decrease in the risk of spread. So 2 important factors for us to consider. So again, we'll be waiting to see what the CDC says next. And as that becomes available, then we'll be making plans to help those folks interested to get their booster doses. So the last piece that I wanted to talk about was COVID vaccines in pediatric patients. So just today, Pfizer came out and said that they've completed their study in patients 5 to 11, and that they'll be releasing that information to the FDA by the end of September. And last time that we heard from the FDA on this, they said that approximately 3 weeks after getting that data from Pfizer, that they would make a ruling on that. So that'll be important for us to also watch for. So that looks towards middle to late October. We'll have some information on COVID vaccine for 5 to 11-year-olds. And one important thing that I want folks to keep in mind is that the dose that they're studying in 5 to 11-year-olds is different. So they studied a 10 mic dose versus a 30 mic dose that patients 12 years of age and older got. So another important reason to wait for that data to be released. None of that has been peer reviewed or published yet. After the FDA gets a chance to evaluate that, then we'll have recommendations for that population as well. So those were the real main points that I kind of wanted to discuss with you guys, but I'd be happy to turn it over and see if you had any questions tied to side effects of the vaccines or some of the other medications we're using to treat COVID-19, or any other questions I can help you with.
Thanks, David.
So again, just to reiterate, well, any questions that we might be able to respond to?
Yeah, hi, this is Corey with the Tulsa World. I thought I just might ask, how much will vaccinating the 5 to 11 population help when you talk about the spread we've been experiencing? We've had less vaccine uptake among the 12 to 18. So I'm just wondering what your thoughts are on that.
Go ahead, David.
Flip for you one. I mean, obviously we're not seeing as much of the pediatric patients being admitted for COVID, so I think that's good news. We're all happy to see when a disease like this isn't impacting kids. So hopefully, that will stay the same, and it may not have as big of an impact on hospitalizations because the pediatric patients are more protected. As far as the spread, I mean, I don't know if I know the answer to that. With the Delta variant coming, it's kind of thrown a curveball to a lot of folks. We have seen a huge surge even after vaccines. If you look to the Israeli data, it does look that getting a booster might help, curb some of that spread. But again, none of that data has been released in those kids, so it's just really hard to say at this point if that's going to help. A lot of it's just going to be tied to how many folks get vaccinated, right? So, until we have a high percentage of folks that either have got COVID or gotten the vaccine or both, we're going to continue to see this disease go through the United States, and the longer we give it, the more opportunity that you get that you're going to see more and more variants. So again, it just goes back to the importance of vaccinating overall.
Yeah, and speaking specifically to that point, for our the St. Francis Health System, for all the caregivers, our entire workforce, I think last week I mentioned, out of about 10,500 individuals, our current data is we have about 6,700, a little over 6,700 that have been fully vaccinated. We have about 2,400 of our coworkers that have tested positive for COVID. So that leaves only about, a little over 1,000, a little over 10% of our workforce that hasn't either had an infection or been fully vaccinated. We are, as a health system, trying to understand the whole concept of breakthrough infections. And although the data on Friday was we've had a total of 212 of our employees test positive for COVID after being fully vaccinated. I mentioned in prior weeks that we're also trying to work with our employees to determine how many folks would qualify as a COVID reinfection. And there's a definition the CDC uses in terms of how far apart you need, 2 positive tests need to occur to be qualified as a reinfection. And as we collect that data and get more comfortable that our data is accurate, we'll share that as well. But one of the challenges we all have, society, our country will have, is understanding that fully vaccinated folks may in fact still contract COVID. What we're trying to learn is, are vaccinated folks less likely to spread the virus to others than somebody that was unvaccinated? And at this point, I don't, there's some suggestion out there that that may be the case, but I don't think there's any definitive data as of yet. So from a healthcare perspective, that is just one more data point that leads us to believe that we're going to be dealing with COVID for some period of time, hopefully at a very low level, endemic level in our community, that isn't something that has these surges or these waves that we've experienced over the last 18 months.
Thank you. And I have a question from a direct message. I've read that heart inflammation is a common side effect of the vaccine. Is this true, and should people be worried? I think this is for David.
Yeah, great question. Again, that's, I think, been a hot topic in the media, and lots of literature out there on it. So I think if you're not aware, that is a new warning that's been added to the vaccine. So again, a lot of this data came from an Israel study. And what it showed is that, first of all, I should probably start with, is that myocarditis or heart inflammation is a low likelihood from the vaccine and a low likelihood from getting COVID. But the Israel data showed that there was about a 3-fold increased risk of myocarditis after getting the vaccine. But when they looked in patients that had contracted COVID, it was actually an 18-fold increased risk. So the patients that had COVID actually had a higher incidence of myocarditis or heart inflammation than those patients that had gotten the vaccine. So again, thankfully, it's a very, very low likelihood in both cases, but a much, much higher likelihood if you contract COVID than if you get the vaccine.
Thank you. Any other questions?
Thank you. I appreciate it. I just wanted to follow up from my original question. When you talk about, roughly 10% of St. Francis employees haven't been vaccinated, what are the reasons you're hearing for that? What's the hesitancy or complacency, and how are you working to combat that?
Yeah, thanks for the question. We as an organization have decided to take a thoughtful approach to this whole issue of the vaccine, mandating the COVID vaccine for our staff. And the reason we've taken that approach is because when we sit down and listen to our staff, which we've done, we've had hold focus groups and listening sessions. There's a more than a majority or slightly more than a majority of our staff that have chosen to be vaccinated and believe that was in their best interest and in their families and loved ones' best interest. But we do have a minority of our staff that really have given the two predominant reasons have been, I already had COVID, and I believe that my natural immunity is, maybe as effective as a vaccine. So that's probably the number one reason people have given not to choose to be vaccinated. The second is just young women, childbearing age, who may be considering future pregnancy or having a family in the future, and they've expressed concerns about there isn't long-term data around the impact of this vaccine and what it might have on a future pregnancy or fertility, et cetera. And while there is data that shows the vaccine is safe and safe to use in pregnancy, what our employees that have expressed that concern have said is that, yeah, but it's not 5 years of data, it's not 10 years of data showing that there's not some unforeseen consequence. So those are the two primary reasons that have come up. There's some other very, very rare concerns that have been raised in terms of not trusting the FDA's process, et cetera. But the vast majority of our employees that have chosen not to be vaccinated really fall into one of those two categories as their primary reason.
Anything you want to add to that one, David?
Yeah, I mean, I'll echo what Dr. Robertson said, and one thing that I will comment on is that one thing that I think people should consider is that COVID-19 and having pregnancy does have there's adverse outcomes in terms of pregnant women that contracted COVID-19, and so increased risk of ICU stay, increased risk of mother mortality, increased risk of preterm birth. So I do think it's important for pregnant women to consider this and to talk with their primary care physicians. I know that all the major medical organizations have recommended it in pregnant patients. And so I totally understand that's a difficult decision for every woman in this category to make. And that's why I'd encourage you to talk with it about your healthcare professional.
Thank you. I have another one in direct message. What are the current treatment options for COVID?
Yeah, so there's multiple different medications that we have right now. That's one of the the great things that we've seen since our last surge is that more medications are available. So there's a couple of monoclonal antibodies that have some outpatient data on. So these two medications kind of work similar to the vaccine in the sense that they're an immune globulin that targets the spike protein and prevents it from binding. And so what these have really been shown to do is decrease the risk of hospitalization, decrease mortality from COVID-19. So carasevimib, which is REGEN-COV, that's a medication that we've been using most frequently on the outpatient side. Again, really good data on it. And then, if a patient is admitted, there's multiple other medications there as well. So the newest medication that's specifically for COVID is a product called remdesivir. It's an antiviral. So if you think about it, kind of like a Tamiflu right now, the data on it shows that it decreases the length of hospital stay. And then there are several other medications, some like dexamethasone, that are tried and true medications. It's a steroid that's been around for decades that decreases the mortality on patients that require oxygenation. And then a couple other medications that actually have their data is originally from rheumatological conditions like rheumatoid arthritis, so baricitinib or Actemra. Those medications are only really for a specific subset of patients that are kind of having a large inflammatory reaction to coronavirus. And this kind of works to kind of calm down their immune response, and again, it decreases mortality. So those last two medications that work on the immunological response really both decrease mortality as well. So again, a lot more treatment therapies and data are available now than the first time we had a surge. So I think that's the good news. And there's quite a few medications that are also in the pipeline So hopefully we'll get some good news from those in the coming months.
Thank you. Any other questions from the group?
I have a couple of questions. Hi, this is Elizabeth from Public Radio Tulsa. I was wondering, what was your reaction to the FDA committee's advisory? I was surprised because you keep mentioning that the Israel data, which as I understand it, is the best data that we have because they test so much. So I was surprised to see it. I was wondering if you were also surprised.
What were you surprised to see? That they
didn't recommend it. They only approved it for 65 and over.
Gotcha. I gotcha. Yeah, I don't know. I think a lot of us probably share some of your surprisement. I think some of it is that we are still seeing good effects, as I kind of showed, in terms of preventing hospitalizations and mortality. So I think that was the big focus that the FDA advisory committee put it on was let's make sure that we're preventing bad outcomes from the virus. Some of the data on preventing spread, like Dr. Robertson had alluded to a little bit earlier, we're still trying to understand some of that. Okay, so I think that's probably where their biggest focus is. Instead, looked at the most at-risk groups, which would be over 65, and those at risk of developing severe illness. The other piece that they want to look at is, there's not as much data on adverse effects with the third dose as there is with the first two. And so, as we get more data on does that change the adverse effect profile at all, we'll see if that expands. And that's actually similar to the approach that Israel took. So when they first approved it, they approved it in over 60, and now they've actually approved it in all ages, I believe. So, we may see that change over time. I think, time will tell.
Thank you. I had my second question was, you talked about hitting endemic status, which I heard from OSU that we're gonna maybe reach that in spring, which would mean that we might have a couple of more spikes. Have you been talking about that at all? And what are you thinking about additional spikes?
Well, so I'll answer that, and then David, feel free to chime in. Again, without getting too far out over my skis as a former family doc, I just look at our employee population as a bit of a window into the community. Now, granted, in general, we're more vaccinated than what you see across the state of Oklahoma, meaning our employee base is about 65, 66% fully vaccinated. But when you add on those that also have been, that haven't been vaccinated but have been COVID positive, you now get up to, as I mentioned, almost 90% with some form of exposure, which theoretically will create immunity. I don't know, I don't know how to predict what this is going to look like over the next few months. I kind of had a sense that unless we get another sort of novel variant that our immune systems don't recognize, I would begin to think that we've got a fair amount of folks in our community that will at least have some degree of immune response to a novel variant. So I think it'd be great if it was spring. It might even, I'm not 100% convinced that winter and COVID is going to necessarily be a problem. What I do worry though is, all of the other respiratory viruses and illnesses that we normally deal with that tend to be more seasonal, we may continue to see that activity at maybe higher than normal levels. I mean, we've been distracted, not thought about influenza much. Influenza it can be a serious viral infection that can be very detrimental to people that have other medical comorbidities. And so I don't know exactly how to answer that question. I think it'd be great if by spring we were at a low level of COVID infections in the community. It could be even earlier than that, but we still have other viruses that we need to be thoughtful about.
Thanks. I guess my concern is that we've kind of seen this coming almost every time. And it concerns me that we would have another spike and we would yet again be unprepared. Do you know what I mean?
When you say be unprepared, are you speaking to healthcare specifically or more societal?
Well, healthcare, I guess, because we see these, really worrying stories about overcrowding and shortages. And so if you can see it coming, it seems, are you doing anything for another spike is really what I'm asking. Thank you.
Sure. So what's different about how we operate today than before COVID is, one thing that's very different is that we are very thoughtful about creating enough supply of our critical supplies to be able to handle another surge. So, back in the days pre-COVID, every health system in the country was really focused on just-in-time inventory and not having big stocks of excess supplies to be efficiently managing our supplies. I would tell you that we have a different perspective today, and that we do have, stocks of N95s and other personal protective equipment, the gowns that are required, because we do need to be prepared for, the next wave should that occur. The biggest challenge in preparation is staffing. And as we've talked about in prior calls, what we are seeing is that acute care nursing staff in particular, but all clinical staff, they can move around the country, go work as itinerant, labor, contract labor, can make more money than they would make in their full-time job. And so we do see that occur, and that is an issue around the country. And so that makes it a little bit more challenging, because you can't predict exactly when you are going to need those folks. And quite frankly, there may be another part of the country that is in more dire straits and needs the staffing resource more than we might need. But that's going to be the biggest challenge, and particularly if we continue to see these waves of COVID infections with new variants, that I don't know how we solve that in the short run. There's just not enough staff to go around.
Yeah, I can just add on too, from like a pharmacy perspective, since you're talking about concerns with shortages. Actually dating back to the hurricane that hit Puerto Rico, which had a huge impact on pharmacy supplies. I actually have a team that meets once a week that solely focuses on drug procurement, supply procurement, to make sure we have all the products that we would need. And we look at this stuff daily, but once a week we go through anything that we have concerns. And thankfully, I'm blessed to work at a health system that we're able, when we see some of those concerns happening, to buy enough product to make sure that we're in good shape to treat our patients and treat the patients of Tulsa. And so that's not stopped actually since then. And when the first wave hit, it doesn't mean that you're not going to have challenges. You're not going to have unforeseen, demand for certain drugs that you weren't expecting. But we're able to quickly adapt to that and to make sure we buff up our inventory so we've got enough product to keep our patients safe. And so it's certainly presented challenges, but we've got a fantastic purchasing group in my department, and I've been really proud of how they've been able to stay ahead of the shortages.
We have a question from Mariah with Fox 23. As we get closer to flu season, is there a push towards people getting their flu shot? If people still need to get their COVID vaccine, can they get that at the same time as their flu shot?
Great question, and I think I meant to mention that in my talk, and I left it out. So yes, you are able to get both your flu vaccine and your COVID vaccine on the same day at the same time if you choose. So obviously, we're always in favor of getting your annual flu shot. This year should be no different. I sure hope there's an added push for people to get their flu shot. And if that makes it easier for you to get them both at the same time, then you can. I think that's just up for each individual to decide.
And I'll add on, Historically, St. Francis has been a leader in the Tulsa community in terms of making vaccine available, flu vaccine available, and once again we will have our drive-through vaccination set up so that we can make it maximally convenient for folks to get their flu shot, and if needed a COVID booster, or potentially a first COVID shot if we still have somebody that hasn't been vaccinated.
Thank you. I'm not seeing any other questions.
So I will close then if there are no other questions. Again, thanking you all for taking the time and allowing us to share some information with you. If there's additional follow-up or other questions, obviously you can reach out to Siobhan or Lauren directly, and they can help run down the answer. But we very much appreciate what you do and your role in educating the public about this virus, this vaccine, the subsequent illness if you're not vaccinated. These are all important topics, and we very much appreciate your assistance in educating the general public. So thank you, and we'll see you again in a week.